Okay, good afternoon. It's now 3:46 p.m. and we're going to reconvene for our polio vaccine session. Our first speaker is Dr. Oliver Brooks, who's the chair of the polio vaccines work group. Dr. Brooks?
All right, thank you, Dr. Wharton. So, next page, thank you. So, in terms of the work of the work group between last meeting and now, what we will be looking at and having discussion in terms of policy today is considerations for the potential use of novel type 2 oral polio virus, or NOPV2, as an outbreak control measure in the United States. Then in terms of fractional IPV, clinical considerations for children who receive fractional dose inactivated polio vaccine, fIPV, in other countries, and then now are here to determine what their true vaccine status is and what we should do with them. So thank you. With that, I'll turn it over to Dr. Kidd, our CDC work group leader.
Thank you, Dr. Brooks, and thanks, everyone. Today, I'll be presenting on behalf of the polio vaccine work group members, and I'd like to start off by thanking them and acknowledging all their work here, especially our chair, Dr. Brooks. First, I'm going to start off with just a little bit of background to set the stage for both this discussion and for the next presentation. Poliovirus infection can cause poliomyelitis and lifelong paralysis, but it's important to recognize that paralytic disease occurs in less than 1% of infections, and approximately 75% of infections are asymptomatic. There are 3 poliovirus serotypes, types 1, 2, and 3, and immunity to one serotype does not result in significant immunity to other serotypes. Also, the 3 serotypes have different epidemiological and clinical qualities. For example, the ratio of paralytic cases to infections varies by serotype, ranging from approximately 1 in 190 infections for type 1 to approximately 1 in 1,900 infections for type 2. Poliovirus is considered highly infectious and is spread through the fecal-oral or oral-oral routes, but fecal-oral transmission is considered the most important pathway, particularly in settings with suboptimal hygiene and sanitation. Virus may be present in stool of infected persons for up to 6 weeks and sometimes longer. And importantly, individuals who have only minor symptoms or who are asymptomatic can still shed virus and transmit it to others. The inactivated polio vaccine, or IPV, is the only polio vaccine used in the United States since 2000. It contains inactivated polioviruses types 1, 2, and 3, and it cannot replicate, infect, or cause disease. It induces effective humoral immunity and prevents paralysis. It also induces some nasopharyngeal mucosal immunity. However, it does not provide substantial intestinal immunity or prevent gastrointestinal shedding. Oral polio vaccine, or OPV, is no longer used in the US. It is a live attenuated vaccine that can come in different formulations. Trivalent vaccine, or TOPV, contains poliovirus types 1, 2, and 3. Bivalent vaccine, or BOPV, contains types 1 and 3 poliovirus. And there are also monovalent OPVs that contain just a single serotype. OPV replicates in the gut and is shed in the stool, and it induces both humoral and mucosal immunity so that it prevents paralysis and transmission of poliovirus. For this reason, it has been considered the historical vaccine of choice for countries experiencing polio outbreaks. However, the attenuated vaccine virus can revert to a neurovirulent form that causes paralysis. And that brings us to novel type 2 oral polio vaccine, or NOPV2, which is the topic of this presentation. NOPV2 is a next generation version of the Sabin monovalent type 2 oral polio vaccine, and it was designed to be more genetically stable and less likely to revert to a neurovirulent form. Between March 2021 and December 2023, almost 1 billion doses were administered as part of outbreak responses in 35 countries under a WHO emergency use listing approval. And as of December 2023, it earned WHO pre-qualification status. In the US, the incidence of paralytic polio decreased rapidly after the introduction of the Salk inactivated polio vaccine in 1955. The Sabin oral polio vaccine was used for routine childhood immunization for decades, but in 1997, an enhanced potency IPV was introduced as part of a sequential schedule with OPV. And then in 2000, the US moved to an IPV-only schedule. IPV has been the only polio vaccine recommended in the US since that time. Wild poliovirus type 1 and vaccine-derived polioviruses are still circulating in certain parts of the world. And this figure shows the distribution of approximately 450 paralytic polio cases caused by wild poliovirus type 1 and circulating vaccine-derived polioviruses that have been identified in the last 12 months. Of note, environmental detections, for instance from wastewater, are not shown on this figure. And then, as you are aware, a case of paralytic polio caused by vaccine-derived poliovirus type 2 was confirmed in an unvaccinated young adult from Rockland County, New York on July 21st, 2022. Genetic sequencing has indicated a linkage between this case to polioviruses collected in wastewater in Israel and the United Kingdom, and then subsequently Canada. Of note, Rockland County has reported overall low vaccine coverage for over 20 years. And in the summer of 2022, when this case was identified, only 60% of children under 2 years of age had received 3 doses of IPV, and zip code level coverage in the area was as low as 37% in some areas. Fortunately, no additional paralytic cases were identified. Poliovirus related to the case was detected in wastewater in several New York counties and in New York City. Retrospective testing detected poliovirus in the area as early as April 2022, indicating circulation and asymptomatic infections in the area since at least that time. Related virus continued to be consistently detected in wastewater until the beginning of November 2022, and the most recent detection was a year ago on February 22nd, 2023 in Rockland County. Samples collected in the last year have all been negative. And this figure shows the pattern of wastewater detections in each affected county by week, with poliovirus detections depicted in red and negative poliovirus samples in blue. The primary vaccination response to the 2022 outbreak was focused on identifying unvaccinated and undervaccinated persons and providing catch-up vaccination with IPV. However, in the fall of 2022, when there were still wastewater detections of poliovirus, it was unclear whether this strategy was going to be sufficient to interrupt circulation. WHO recommendations for polio outbreaks in countries like the US with exclusive IPV vaccination and high sanitation and hygiene are to conduct a timely outbreak response with IPV only if poliovirus transmission is confined in a well-defined population group or geographic area. However, if transmission persists, WHO recommends considering an OPV response. So the work group was asked to discuss considerations for the potential use of NOPV2 as an outbreak response measure in the US. The New York outbreak had already waned at the time of the work group discussions, so the question the work group took up was really a theoretical one. Should NOPV2 be used in combination with a catch-up IPV campaign during a future type 2 poliovirus outbreak in the US? And just to clarify, the population that we were considering would be persons living in an area with circulating poliovirus. The intervention would be NOPV2 vaccination for the general population, in addition to catch-up IPV vaccination for un- or under-vaccinated persons. And that would be compared to the intervention that would just be catch-up IPV vaccination only. The outcomes of interest were prevention of paralytic polio, extent and duration of poliovirus circulation in the community, as well as serious adverse effects, including vaccine-associated paralytic polio and possible introduction of a new vaccine-derived poliovirus type 2. And the work group used the ACIP evidence to recommendations framework and domains to frame their discussions. Based on the information that I've presented to you, the work group had previously agreed that polio is a problem of public health importance. Moving on to the potential benefits and harms, there are high rates of seroconversion following 1 and 2 doses of NOPV2 when administered to infants. Among infants who had already received 1 dose of IPV, 86% seroconverted after 1 dose of NOPV2 and 98% seroconverted after 2 doses. Among vaccine-naive infants, 46 to 64% seroconverted after 1 dose of NOPV2 and 86 to 90% seroconverted after 2 doses. However, given that we already recommend vaccination with IPV in this country, the main benefit of NOPV2 would be to confer gastrointestinal immunity. Sabin OPV2 reduces the odds of fecal shedding following a subsequent oral challenge dose by more than 90% compared to no vaccination. There are no direct data for NOPV2, but it has performed as expected in the field in terms of slowing or stopping outbreaks. And in a small phase 1 study among adults, a small phase 1 trial has shown evidence of gastrointestinal immune response following NOPV2 administration in adults. We know that NOPV2 is a live virus and it is shed in stool by NOPV2 recipients following vaccination. When measured by PCR, 85% had detectable vaccine virus in stool at 7 days, and this decreased to 40 to 57% by 28 days. When measured by culture, which is probably a better measure of infectious virus, 40% were shedding at 7 days, and this decreased to 1 to 14% by 28 days. And then finally, we know that NOPV2 was developed to be more genetically stable than Sabin OPV2, and it's been shown to be less likely to regain neurovirulence in the lab. However, there's still a risk of vaccine-associated paralytic polio, or VAP, in recipients. The estimated risk of VAP for NOPV2 is estimated to be 0.07 cases per million recipients, or 1 case per 14.3 million recipients. This is compared to Sabin OPV, with an estimated case rate of 0.25 to 4 cases per million recipients, or 1 per 0.25 million to 4 million recipients. And we know the risk of VAP is highest in previously unimmunized children who are receiving their first dose of OPV, or in immunocompromised patients. And the risk of VAP could be mitigated by limiting NOPV2 administration to persons who had previously received at least 1 dose of IPV. We also know that there's a risk of ongoing transmission of the NOPV2 virus with reversion to a VDPV. This risk is difficult to quantify, but so far we know that there have been at least 7 separate emergences of a new CVDPV2 linked to NOPV2, and at least 61 associated paralytic cases worldwide from these emergences. I'll note that these are numbers that have been published in the literature so far, and that the actual numbers are likely higher as NOPV2 use increases globally. However, NOPV2 is estimated to be 80% less likely than Sabin OPV to seed a new VDPV2. And the risk of a new VDPV is highest when campaign coverage is low in a population with low immunity against polioviruses. So when thinking about the balances of risks and harms for the individual recipient, most recipients will have already been vaccinated with IPV during childhood immunization, and therefore already protected against paralytic disease. So the anticipated benefits of NOPV2 to the individual recipient would be a higher anti-polio type 2 antibody titer and increased odds of mucosal immunity to poliovirus type 2. For an under-vaccinated person, this would mean additional protection against paralytic disease. However, for a previously vaccinated person, there is unlikely to be a clinically significant benefit of vaccination. For potential harms, there is an extremely low but non-zero risk of VAP, And there's a risk of chronic infection if NOPV2 is given to a child with unrecognized immunocompromise. At the population level, decreased transmission among NOPV2 recipients could potentially result in the outbreak ending earlier and fewer paralytic cases. And as the vaccine virus can be shed in stool and transmitted to others, there would likely be some degree of passive vaccination of unvaccinated persons, which would also lead to decreased transmission and fewer paralytic cases. Potential harms at the population level include passive vaccination of the unvaccinated and a risk of VAP among the unvaccinated, possible ongoing transmission of the NOPV2 virus, leading to a new CVDPV2 virus, and also possible chronic infection in immunocompromised persons. The magnitude of these benefits and harms will depend on NOPV2 coverage and the extent of mixing between NOPV2 recipients and unvaccinated persons, and also immunocompromised persons. And so for this, we can turn to modeling. Kim Thompson and her colleagues at KidRisk modeled the expected number of paralytic cases under different mixing scenarios for a CVDPV2 outbreak similar to the 2022 New York outbreak. They compared the number of cases expected with an IPV-only response to responses that used a Sabin OPV2 or an NOPV2. In their model, they assumed that the number of vaccine doses administered was the same as the number of IPV doses that were actually administered during the 2022 New York outbreak. They concluded that use of any type of OPV2 would likely have ended transmission slightly earlier than with IPV alone. However, as you can see here, less than one additional paralytic case was predicted in all IPV or OPV2 vaccine scenarios. They also ran a similar model, but for a VDPV1 outbreak instead of a VDPV2 outbreak. And remember that type 1 poliovirus infection is associated with a higher rate of paralytic disease than type 2. So the results of this model suggested that use of an OPV1 would likely end VDPV1 transmission faster and result in fewer paralytic cases than use of IPV alone. So when assessing how substantial the desirable anticipated effects of NOPV2 are on both the individual and population levels, approximately half of the work group felt the desirable effects of using NOPV2 in addition to IPV were small, but some members felt that the desirable effects were minimal and some felt they were moderate. When asked about the undesirable anticipated effects, the work group was evenly divided between minimal, small, and moderate. But when asked whether the desirable effects of NOPV2 outweigh the undesirable effects, half of the work group felt that the desirable effects did not outweigh the undesirable effects and that the information favored the use of IPV only. However, about a third of the group felt that it varies depending on the situation. Moving on now to resource use and feasibility. NOPV2 is not yet approved for use in the US, so if we wanted to use NOPV2, the mechanism we'd be using would be the Expanded Access Investigational New Drug Application, or EAIND, formerly known as compassionate use. Oops, sorry. Did I skip ahead? There we go, okay. This requires application to the FDA and FDA authorization. And if implemented, the NOPV2 EAIND program must include a signed informed consent by vaccinees and/or their guardians, an enhanced system for monitoring vaccine safety, an enhanced surveillance for possible vaccine-associated paralytic polio cases, and environmental surveillance for new VDPVs. In addition, it would require a system for tracking and accounting for every single dose for containment purposes. And this includes every dose given, every dose wasted, and doses So there was a variety of work group opinions on whether this would be a reasonable and efficient use of resources. Half of the work group responded that it was probably not a reasonable use of resources, but about a quarter responded that it varies depending on the specifics of the situation. The work group was also divided about whether an NOPV2 campaign would be feasible to implement. Half of the work group responded that it was probably feasible, but about a third responded that it was probably not. So for values and acceptability considerations, trivalent OPV or TOPV was removed from the US vaccination schedule in 2000 and was replaced with IPV because any risk of VAP was deemed unacceptable at that time. So this removal might be a barrier to acceptance of a new OPV vaccine in the future. In addition, the need for assigned informed consent will likely be a deterrent, especially for those who are concerned about vaccine safety and new vaccines. And it is unclear whether the general public will accept an OPV vaccine if they are already protected from paralytic infection by IPV. So in other words, will they accept a vaccine to reduce community transmission and risk to others if they don't benefit from it individually? And then it's also, similarly, it's unclear whether the populations most at risk, those with low childhood vaccination coverage and high rates of vaccine skepticism, will accept an OPV vaccine. But the work group noted that perceptions of risk and vaccine acceptance might shift in an outbreak setting, particularly if there is more than one paralytic case in a community. So a clear majority of the work group agreed that the target population probably does not feel that the desirable effects of NOPV2 are large relative to the undesirable effects. However, they were divided about whether there was important uncertainty or variability in how much people valued the main outcomes. The work group was similarly divided about whether NOPV2 would be acceptable to key stakeholders, with some saying probably no, some saying probably yes, and some saying that it varies. In terms of equity, there is only one manufacturer of NOPV2, and it is managed by a global stockpile. Supply shortages have occurred in the past. In the US, IPV is readily available and provides protection against paralysis from CVDPV2. But in many countries with CVDPV2 outbreaks, there is limited protection against CVDPV2 unless there are NOPV2 or Sabin OPV2 campaigns. In terms of equity within the US, the work group noted that preventing transmission of the outbreak virus does protect unvaccinated and undervaccinated persons as well as immunocompromised persons. Again, there was a spread of opinions on the work group, but the plurality of the work group felt that using NOPV2 would probably not have a significant impact on health equity. So putting it all together, overall, most of the work group felt that the undesirable consequences of using NOPV2 during an outbreak in the US probably outweigh or are closely balanced with the desirable consequences. In summary, at this time, the work group believes the undesirable consequences of using NOPV2 are probably outweigh or are closely balanced with the desirable consequences. The main considerations for the work group's interpretation was that IPV is readily available in the US and protects against paralytic disease, and that the primary benefit of adding NOPV2 to an outbreak response would be to reduce transmission of outbreak virus and reduce risk of paralytic disease in undervaccinated and immunocompromised persons. There were differences of opinion regarding the value of reducing asymptomatic transmission or ending asymptomatic transmission earlier during an outbreak. The work group was concerned about the extremely low but non-zero risk of VAP, or a new vaccine-derived poliovirus. And there was uncertainty about public and stakeholder acceptance of a novel OPV2 vaccine. the work group did acknowledge, however, that the balance of undesirable consequences compared to desirable consequences might shift in the future depending on size and scope of the outbreak. And as modeling showed, particularly the calculus might be different for a type 1 outbreak where more paralytic cases would be expected and public perception of risk might be higher. So that concludes my presentation. Thank you.
Thank you, Dr. Kidd. Are there questions or comments for Dr. Kidd? Yes, Dr. Brooks.
So before we open it up to the group, there was a desire to have the FDA comment on this to add to the presentation, if you will, and then, if you will, go from there.
Dr. Kaslow, is there anything you'd like to add to this?
Not at this time. Not at this time.
Okay. So let me just comment then that there was some discussion that the FDA, you saw everything the FDA would have to go through to allow utilization. So during the work group discussion, and I can't remember who it was that was representing the FDA, but they were of the opinion that that would be a challenge from the FDA side. So I'll leave it at that, and then we can open it up for discussion.
Well, I obviously would defer to Dr. Kaslow, but I expect there would be substantial regulatory issues with use of this product in the United States. But
yes, as delineated in one of the slides.
Dr. Cotton and then Dr. Daly.
I was wondering, thinking about the immune-compromised host, you mentioned immunocompromised children who might get the vaccine and who could directly, suffer the consequences of having live viral vaccine exposure. What about introducing this into the community with, there's a new paper where over 6% of Americans identify as immunocompromised or having immunocompromising conditions or are on immunocompromising medications. And so that's a significant part of the population, and they may or may not be well polio vaccinated, especially, there are various age groups that would be represented. So one of the more recent cases of polio in the United States was a woman who had common variable immunodeficiency who was exposed to her child. And after many, many years of incubation, she suffered from paralytic polio from the vaccine strain. So I wonder, was that taken into consideration in the work group, not just the impact on immunocompromised or children who are not yet known to be immunocompromised, but as well as introducing this into, the community and whatnot?
Yes, I think, so certainly immunocompromised would be a contraindication to receiving any oral polio vaccine. And I think yes, if that was not articulated, I think we should have, anytime you have a virus circulating in a community, then that's a risk to immunocompromised persons. So even the vaccine virus, so probably persons who even have an immunocompromised person in the household would probably that would be a contraindication to giving it to those children or people as well. But that would be an additional risk.
I don't think that we routinely screen for family members who are immunocompromised. I don't know, maybe some of the pediatricians could comment as to whether that's a routine practice. So you wonder if that's...
Again, this would be an informed consent, so there would be some discussion of all and again, probably also in this theoretic scenario, to mitigate risk of VAP would be limiting NOPV2 use to persons who had already received 1 dose of IPV. So, to think that if this was actually going forward, it would be including documentation of that and then some of these other potential risks that would increase the risk.
Thank you.
Yeah, I just have a couple of clarifying questions. More so I understand the problem. I realize it's sort of not an active sort of discussion at this point, but and there are like 3 or 4 of them, but I think they're short. So the case in New York was vaccine-derived, and it was vaccine-derived type 2, is that correct?
Yes.
Okay, and then if someone already carries that intestinally, then getting a novel OPV doesn't actually provide them that individual clinical benefit. Is that true?
So a person, so either the circulating virus or the vaccine virus would be expected to replicate in the gut for up to 6 weeks, typically. I don't know the answer to the question if a person had been recently infected with circulating VDPV2 and then got novel OPV2, if post-exposure, if vaccination offers any protection. I don't know that off the top of my head.
Okay. And then when we're talking about, and in some ways this question, it's a very basic question because it's not a content area I'm really familiar with, but when we talk about breaking community spread, it doesn't, in the US, have anything to do with wastewater and contaminated water. It's really more of sort of local spread, where that might be in a household or a daycare setting or something like that, where individuals who are not protected are coming in contact with other individuals, not through any problem with the water supply. It really literally is just sort of a
Correct. We don't think people
direct
are
contact
necessarily getting it from the sewage or wastewater in the U.S., but the wastewater is a reflection of community transmission through household contacts or school contacts or otherwise community contacts.
Right, and so then, and the reason I ask that is just that the mechanism of stopping the outbreak is that it is providing immunity to those in the immediate community around those cases, some of which haven't been detected yet. Is that
Correct,
right?
yes.
Okay, okay. Thank you.
Dr. Chin?
Yep, so I think, thank you so much for the work group in considering this policy question. And I'm agreeing kind of with the assessment that was made. But I guess the larger question for me is, these are trying to address communities, populations that are under-vaccinated. They will be under-vaccinated against polio type 1. And so NOPV2 would only address type 2 and not type 1. So I guess we also need to continue to see if there are ways to address future outbreaks of PV1 and 2. So I do have a question. So what is the perceived obstacle or barrier to vaccination in many of these communities? I didn't get the sense that we heard about an oral vaccine being more acceptable than a parenteral vaccine, and ultimately it's really just trying to overcome an overall sense of vaccine hesitancy in these communities is my impression, but again, I didn't hear specifically addressing that, and I don't know if that was a separate discussion in the work group. Just trying to understand, and I guess one thing that I was struck with was that there is the precedent that any VAAP event is unacceptable previously, and that's why we went with IPV. And, in an outbreak situation, I guess we're saying that we may have a different perception, but again, that precedent had already been made in about 2000, right? So that's kind of a difficult kind of mountain to surmount when you've already made that precedent. So that's just kind of a comment. But the ultimate question really is what's the perceived obstacle or barrier to vaccination overall in these communities, and then trying to come up with solutions.
I think there was some regarding the oral rotavirus vaccine. I think there were some previous vaccination studies that say some parents were more inclined to give an oral vaccine than an injection. However, in the polio outbreak scenarios, it's not limited access to vaccine, right? It's distrust of the medical system, don't see it's necessary, distrust of government. And so I think you're correct that I don't think an oral vaccine would be more likely to be taken than the IPV. And in fact, the mitigation strategy, we probably would not want to give an oral vaccine in the absence of an IPV. We would probably want to give IPV and then in addition to oral polio vaccine for persons who are under-vaccinated. So I think that's the kind of catch-22 is that the persons who are unvaccinated have already might be reluctant to get vaccinated, period, and then to say, okay, now we want to give you 2 vaccines. I think, yeah, it's questionable whether it would be acceptable, and I think that's what was reflected in the work groups. Polling was that there was unanimity, or close to unanimity about that this is probably not acceptable right now in the population of interest.
Dr. Lehr.
A follow-up question on that. Do we have any information about the community in downstate New York, Rockland County, when they had a case of polio in their community, and I presume that they had polio vaccine clinics, how much uptake happened at that time? Did they go from 70% to 75% to 80%? Were the clinics well received, or were they still avoided? I'm just wondering if we have any data on that. Thank you.
There are some data. It did, when you compare it to so this occurred in 2022, so when they looked at the same period during 2021, the uptake, it was increased above the 2021, and the coverage did increase slightly among children in particular. However, there was a few limitations to that. One is that during the outbreak, it was more mandatory reporting of vaccine doses given, and so that might have been affecting some of that increase. And also in 2021, it was still during the pandemic when their vaccine rates had kind of dipped. So it was comparing to potentially a high to a low. So it's unclear whether there was really it was not a large increase in uptake, but there was some increase. I'll leave it there.
Thank you. Dr. Cotton, and then, okay, so not a new, okay. Are there any additional questions? Dr. Brooks.
So just looking back on a few statements. So for Dr. Cotton, for the immunocompromised, the primary concern was them, if they got OPV or oral polio, that they would shed, or the concern was the continued shedding. The immunocompromised could get IPV. And so the question would be, do they have less gut protection with the IPV? And I don't know if there are any studies that show that one way or the other.
I think Dr. Kidd answered my question. I was actually concerned not about direct inoculation of the immunocompromised. Of course, I'm worried about that, but that's already been mentioned and discussed. I was worried about community exposure of the immunocompromised person who is not aware that they're being exposed to polio vaccine. In the Yellow Book, there's a recommendation about people who are immunocompromised who travel to regions of the world where they are giving oral polio vaccine, and that they should be aware of the risk of exposure to oral polio, live viral oral polio vaccine in those regions, so that they could practice good hand washing and just be aware of that theoretical risk.
Okay. And then just in general, in terms of deliberations of the work group, this was a theoretical, and the thought is that if you saw 10 polio cases somewhere, that all bets are off. So right now in Rockland, it burned out. There is no longer risk of polio theoretically from what we see. And the other main consideration was that the benefit is to those that are or under vaccinated. Has absolutely no benefit to the majority of the population, which is vaccinated. So you would have the potential risk of a VAP, and it's those that are getting vaccinated that would cause the risk, and those that are not vaccinated are doing nothing. So in the end, those were major considerations in terms of us at this point in time saying we don't recommend NOPV.
Dr. Keslow?
Yeah, thank you. Just following up on Dr. Daly and Laura's question, in this limited outbreak setting and coverage, what is the sweet spot for coverage to have the maximal transmission blocking effect? And kind of where does that start? And then where beyond that coverage are you not getting any added value in terms of breaking the transmission in that population? Is that understood?
I do have Dr. Thompson, Kim Thompson from the modeling on the line, and she may want to chime in, but I don't know that we know that in the US setting with sanitation. And so I don't think we have quantified what spread is fecal oral versus oral, and then I think you have to take into account different communities, like within the family and then in size of the family. And so I think that's a complex equation. I don't know, Dr. Thompson, did you have anything to add to that?
Yeah, thanks, Sarah. Great question. I think the big challenge here, of course, is that it is going to depend on the specific subpopulation or population where the outbreak is happening, both because the coverage level will depend on the intensity of mixing within that specific population. So I hesitate to give a specific number. And in addition, it will depend on the type of poliovirus. One thing I think that your question and another question that was previously asked really are alluding to is that for these known subpopulations with under vaccination, this is really the time to focus on trying to get the IPV coverage up as high as you can. And not to wait for the outbreak, because we do still have active transmission of live polioviruses around the world importing into the United States. And so this is an ongoing, small but real risk. So hopefully that's helpful. Thank you.
I guess just really quick follow-on, sorry to push on this a little bit, but just to get a sense of it, worst case, best case scenario. So best case scenario, what level of coverage would we likely need to reach in order for this to be an effective intervention? I mean, obviously worst case scenario is we've got to cover everyone, but what's that threshold that we would need? Because I think that would be important to understand in the current context. This can be feasible.
Yeah, so just to make sure I understand your question, you're saying what level of coverage do we need to reach in the unvaccinated individuals in the subpopulation where the outbreak is happening?
No.
In order to stop
total
the
population.
Total population.
That outbreak population that's at risk, what's best case scenario? What coverage do we need to reach in order to break transmission?
Yeah, it's very difficult to answer this question. For type 2 in the New York setting, the number of doses of IPV that they gave was close to 25,000. And that was the 25,000 in the previously unvaccinated or undervaccinated population. So I think the best way to try to get at that would be to say, if you take that number of doses and you look at what the increase in the immunity was, how much did that help? So it's hard to give you a specific threshold number because, in fact, it really does depend on those dynamics in that population. I mean, I think what we want to see is that we don't want to have any parts of the US population with immunity less than 80% to polio. And I think that we do know that there are some places where we have that. So I would worry about those areas if you're looking for that kind of a number. And that would be covering all three types, just based on the transmission dynamics of polio in the United States. So I think that's probably the best estimate to give you overall. Again, it's tough to answer for any specific subpopulation because the dynamics in those populations will differ. But the reality is the IPV coverage is generally very high. So the general population coverage is providing a good buffer. The challenge we have is that individuals who have been born since 2000 and also many individuals born in the few years before that only received IPV, and they are able to actively participate in transmission fairly well because they don't have that mucosal immunity. So they're contributing to the transmission, even though we can't see them because that transmission is happening asymptomatically.
Exactly. It wasn't the IPV coverage, it's the NOPV2 coverage that you need to get and the feasibility of reaching that, because if you can't reach that feasibility, then what you get is right, VAP.
Well, I'll just add, though, that the New York outbreak has appeared to end without NOPV2. So outbreaks do end. It's a matter of the tolerance for how long and how much silent circulation you're willing to tolerate, and then the risk of paralytic cases. So.
Very interesting questions. Any more questions or comments from the committee or any of our liaison representatives who are still on? Well, if not, Dr. Kidd, do you want to move on to your second topic on fractional doses?
Thanks, yes. So the next topic is fractional IPV doses that are administered in other countries. So wild poliovirus type 2 was eradicated in 2015. That's wild poliovirus. And that prompted a global switch in April 2016, during which all the Sabin type 2 virus was withdrawn from routine immunization. And countries that were still using OPV in routine immunization replaced trivalent OPV with bivalent OPV that contained only types 1 and type 3 virus. At the same time, it was recommended that countries that still used OPV include at least 1 dose of IPV as part of their routine immunization schedule. Subsequently, based on clinical trial data and limited IPV availability in some countries, WHO has supported the use of 2 fractional doses of IPV given intradermally in place of a single full dose. We know from previous clinical trial data that 1 fractional dose is less immunogenic than 1 full dose of IPV, and the results of a previous meta-analysis are shown here and show that the reduced odds of seroconversion with 1 fractional IPV dose compared to 1 full dose. Clinical trial data have also suggested that 2 fractional doses are more immunogenic than 1 full dose of IPV. And this figure shows the results of a study showing that 2 fractional doses administered at 6 and 14 weeks of age in the blue bars resulted in higher rates of seroconversion compared to either 1 full dose of IPV administered at 6 weeks in orange or 1 full dose of IPV administered at 14 weeks in the gray. Currently, 6 countries, representing about 20% of the global birth cohort, use fractional IPV in their routine immunization schedules. They all use 2 fractional doses in combination with at least 3 bivalent OPV doses. As an example, I've included India's polio vaccination schedule here on the slide. And you can see that in total, a child would receive 5 doses of bivalent OPV and 2 doses of fractional IPV. For the US, the current US guidance recommends a total of either 3 or 4 doses of IPV, depending on the age of the last vaccination. And the guidance when assessing vaccine records for vaccines administered outside the US is that only trivalent OPV doses or IPV doses are considered valid for the US vaccination schedule. So going back to the example of the Indian vaccination schedule, if a child immigrated from India and wanted to attend school in the US, current guidance is that none of these bivalent OPV or fractional IPV doses would be considered full doses, and the child would need either 3 or 4 full IPV doses to be considered fully vaccinated against polio in the US. So the question for our work group was, should 2 fractional IPV doses administered outside the US be counted as either 1 or 2 doses towards the US vaccination schedule? We conducted a meta-analysis that was an update to the meta-analysis that was previously published in 2021, and conducted a literature review using the same search terms as the previous analysis, looking for randomized clinical trials that compared 2 fractional doses to either 1 or 2 full doses. The outcomes of interest were seroconversion for poliovirus type 2, and also changes in geometric mean titers. So first, I'm going to show you comparisons between 2 fractional doses and 1 full IPV dose. Overall, 2 fractional doses were associated with higher rates of seroconversion compared to 1 full dose of IPV. Infants receiving 2 doses of fractional IPV were 1.5 times as likely to seroconvert compared to infants who received 1 full dose of IPV. Moving on to comparisons between 2 fractional doses and 2 full doses. 2 fractional doses were associated with slightly lower rates of seroconversion than 2 full doses of IPV. But you can see that the risk ratio was 0.9, so close to 1, and some studies seem to show equivalency between the 2 vaccination regimens. And here I'm showing the same figure, but added in the data on age of administration and listed them in the studies in order from youngest age of administration to the oldest. And you can see that 2 fractional doses are less favorable compared to 2 full doses when given at younger ages, but then as age increases, they become more equivalent in terms of seroconversion. Here we're looking at median antibody titers, median antibody titers and mean titers. And regardless of age at administration, all studies show that 2 fractional doses result in lower peak titers compared to 2 full doses. And the differences in peak titers were statistically significant in most of these studies. This figure is from one of the studies that compared multiple different regimens. And you can see that when doses were administered at 10 and 14 weeks, 2 full doses of IPV in the purple bars resulted in significantly higher titers than 2 fractional doses in the green bars. When given at an older age, at 14 and 36 weeks instead of 10 and 14 weeks, the mean titers are higher, but you still see a difference between 2 full doses of IPV and 2 fractional doses. This matters because we do expect antibody titers to decline over time. So it's possible that as titers in persons who receive fractional doses decline, they will reach seronegativity earlier and might be left unprotected against type 2 poliovirus. This figure shows similar rates of decline in both groups, but higher titers with the 2 full dose regimen in the top solid black line compared to the 2 fractional dose regimen in the dotted gray line. So in summary, WHO supports the use of 2 fractional IPV doses in place of 1 IPV dose as an IPV conservation strategy. 2 fractional doses are associated with higher rates of seroconversion compared to 1 full dose, but 2 fractional doses are associated with slightly lower rates of seroconversion compared to 2 full doses. And this is especially the case when administered at younger ages. Peak antibody titers are also lower after 2 fractional doses compared to 2 full doses. So based on this information, the work group agrees with the following proposed language to be included in CDC considerations for persons receiving vaccines, polio vaccines outside of the United States. For persons who received fractional or 1/5 full dose IPV administered intradermally outside the United States, 2 fractional doses of IPV should be considered valid and counted as 1 full intramuscular dose of IPV towards the US vaccination schedule. If a person received only 1 dose of fractional IPV, this dose should not be considered valid or counted towards the US vaccination schedule. Again, that concludes my presentation, but I do want to thank the polio work group members again, especially Adriana Lopez and Conchi Estivares for help with the slides and with the meta-analysis. Thank you.
Thank you, Dr. Kidd. Are there questions or comments for Dr. Kidd on this presentation? Dr. Wang.
You didn't address it, so I suspect you don't want questions or answer the question, but the question would be, so what do you do with them now? If you had a completely unimmunized adult, as in Rockland County, you gave them 2 full doses of IPV?
No, so US vaccine recommendations will not change based on this. Only IPV, full dose IPV is the only polio vaccine recommended in the US. So unvaccinated adults, it's a 3-dose IPV full dose schedule.
I anticipated that, but I thought you said earlier that you might require 3 or 4 more for these poor children to go to school or to be counted as valid. And the question is, if they had 2 fractional that counts as 1, how many more doses would they need to be considered fully immunized against polio? And I don't think the answer should be 3 or 4 or 3.
Right, so this is showing the current status, which is that none of those doses are considered valid. So the person would be considered completely unvaccinated for polio here, and depending on age, if they're over, let me make it easy, if they're over 4 years, that would be 3 full IPV doses. If the person comes in with this new guidance, the 2 fractional doses will be counted as 1 full dose, and the person would be recommended to receive 2 additional IPV doses.
Seems to me that requiring 3 more for 1 under 4 is a lot.
It is a lot, and it's mainly for type 2 protection. As you see, they're well protected against types 1 and 3. I don't know how that moved, with the bivalent doses. So it's really concerning for protection against type 2. Mm-hmm.
Dr. Chin?
Yeah, the only thing that I would add for the clinical considerations or some section is to maybe mention specifically the 6 countries that are routinely using fractional dosing. It may not be immediately apparent like which countries, so I guess, you know, a pediatrician or someone who's intaking international adoptees or immigrants and evaluating this, I think it might be helpful to have that up front so that they're aware of where they should be looking for it. Unless there's another way that it could be definitively documented, because I'm imagining that many immigrants may not have a very good immunization record, so that's why I'm just mentioning it this way.
Yeah, those without records are a different scenario. There's current guidance for that too. But I think that's a great suggestion that we can help guys say at this time, as far as we know, these are the countries. But I think we are anticipating quite a bit of outreach to understand the notations, because the polio vaccination schedule is now getting quite complicated with monovalent, new trivalent, and then fIPV, you know, IPV and OPV. So I think this will be part of a glossary that we'd have to sensitize people, especially people who are evaluating records for school, to have them understand this.
Thank you. Dr. Laird?
So one question, one follow-up. Is the World Health Organization recommendation now just to be giving bivalent vaccine, polio vaccine?
Bivalent with at least 1 dose of IPV.
With at least 1 dose of IPV. Okay, thank you. No follow-up.
Dr. Beigel?
Yeah, just to clarify, for the examples you gave, every country that is doing the fractional dose is giving the bivalent OPV, right? There's no country just doing fractional.
Correct.
Okay, perfect, thanks.
Any other question? Dr. Daly?
Is the plan long-term to use fractional? Because my understanding was it was because of an IPV shortage at a time when there was more circulating vaccine-derived. I mean, you know, polio is still a global public health problem, and then there was a shortage of IPV. So is this a long-term global strategy to use fractional?
I don't know the answer to that question. I think it's country to country that there is 2 doses, 2 fractional doses is still only 40% of 1 full dose, so there is still some cost savings, and I'm not sure how much that factors into the calculations.
Ms. Coyle, did you have a comment?
I actually had a question this time. My question is there a sense of how many individuals might be in the U.S. with a fractional dose? Is there a way to quantify this?
Not very many.
I don't know the answer to that question. It would be, since the years when these started, which would be after 2016, and then would have to calculate by age, estimates of age of immigrants here. So I'm not sure if there are estimates of those types of numbers broken down by age and country. I will just say that we know it's 20% of the global birth cohort, which was surprising given the 6 countries. Yeah, but India is included in that.
So these must be large countries.
Yes, including India, yeah.
Dr. Wong?
The reciprocal of Dr. Beigel's question, are there countries that give full doses that only give bivalent?
Yes, there are some countries that are bivalent, and then their IPV dose is a full IPV dose.
So what is the U.S. recommendation for those people?
The full IPV dose is counted as 1 dose, or any dose of IPV is counted, any full dose of IPV is counted towards the vaccine schedule. But bivalent OPV is not counted as a valid polio vaccine towards the U.S. vaccine schedule.
So those people would need several doses of trivalent IPV in the U.S.?
Correct, if they haven't already had the 3 or 4. Mm-hmm.
Any additional comments or questions? Oh. Dr. Lair.
So to answer your specific question, I think it's very reasonable to accept 2 fractionated doses as 1 IPV and would agree with the work group's recommendation.
I agree.
So Dr. Cotton just said she agrees. Dr. Daly?
Yeah, I agree as well. I just think for frontline providers, I'm not sure what the documentation is going to look like. And you refer to this, but in the past, I've worked with kids who are adopted internationally. And at that point, it was often it was quite difficult to tell. You knew they'd gotten some vaccines, but it was quite difficult to tell who got what. And so often our advice was to completely revaccinate, and obviously that sounds like a pretty challenging for the child and family kind of a strategy, but it was because you really didn't have very much confidence in what they had and what they were protected from. And then for most vaccine preventable diseases, doing titers wasn't very helpful. So I think while I'm in support of this, I think it's going to be hard in practice. Frontline provider, unless the documentation is better now than it has been in the past, and I just don't know coming from these countries how well documented what was given would be received. But if it's well documented and a provider's aware of this, then I think this makes a ton of sense. Thank you.
Would anyone else like to address this particular topic about counting 2 fractional doses as 1 dose that the work group has proposed? Okay, Dr. Kidd, does that wrap up what you
That wraps
needed
up,
from the
yes,
committee?
thank you. Yes, thanks very much.
Okay, well, thank you very much for those presentations and that discussion. We will now move to the agency updates from our ex officio representatives. Dr. Clark, would you like to start?
Yes, thank you. So this is Matthew Clark with the Indian Health Service. We continue to prioritize vaccination as our principal clinical and public health prevention priority. As part of our IHS National E3 vaccine strategy, we seek to ensure that every patient at every encounter is offered every recommended vaccine when appropriate. Following announcement of this IHS strategic initiative in November of 2022, the IHS established the E3 Vaccine Champions pilot program in March of 2023. Since then, the IHS has designated 28 Vaccine Champions pilot sites in 9 of the 12 IHS areas, including federal, tribal, and urban programs. And we've shared clinical and community resources, as well as multidisciplinary best practices to cross-pollinate our IHS system of care and to improve vaccine coverage rates in tribal communities. As part of a proactive strategy of outreach, education, and engagement with our partners in tribal communities, the IHS 2023-2024 respiratory viral vaccine campaign has worked to ensure timely access to immunizations for COVID, seasonal influenza, and respiratory syncytial virus among our vulnerable service population across the age spectrum. Following reported supply chain constraints in the fall, IHS worked diligently to secure a supplemental supply of the long-acting monoclonal antibody nirsevimab to ensure that this life-saving immunization was available in support of ACIP recommendations for administration of nirsevimab to American Indian and Alaska Native infants and children up to 19 months of age. To date, nearly 8,000 supplemental doses of nirsevimab have been distributed and administered to mitigate the risk of serious RSV disease among infants and children in Indian country. Due to persistently elevated rates of respiratory viral illness in Indian country, in collaboration with IHS obstetric and pediatric subject matter experts, last month the IHS Chief Medical Officer, Dr. Loretta Christensen, announced extension of the period for administration of maternal RSV vaccine to eligible pregnant American Indian and Alaska Native persons through the end of February for this season, as we seek to mitigate the risk of RSV in our high-risk service population. Preliminary surveillance suggests favorable uptake of novel RSV countermeasures in Indian country. This is especially true in regions historically most impacted by high rates of RSV-related morbidity and mortality, such as the YK Delta region in Alaska, where proactive efforts by our tribal partners included bush plane flights to over 25 villages to administer nirsevimab to eligible infants and children, many of whom also received other ACIP-recommended vaccines. Moving forward in collaboration with our partners in tribal communities, we will continue to promote access, quality, value, and equity related to immunizations in Indian country. And this concludes the IHS report. Thank you.
Thank you, Dr. Clark. It's great to hear about all that work. Ms. Hance?
Thank you very much. I have two updates, but one of which is sharing some information about a CMS colleague who has been involved with the ACIP for many, many years. If you all are not aware, Dr. Jeff Kelman, who was the Chief Medical Officer for CMS's Center for Medicare, died earlier this month after an illness. As I mentioned, he's been involved with the ACIP for years and years and represented CMS on many different work groups. He was a pulmonologist by training, which fit perfectly into many of the work that he did supporting CMS on the influenza, the pneumococcal, COVID, many, many work groups. And in addition, really worked closely with FDA on using data, and was absolutely committed that there was data, flu data in particular, that could be used across agencies, and was just very valuable data that should be available for use. So I wanted to acknowledge that and recognize him first. And then I have one just small update, which is to just note that on February 12th, on the Medicaid side of CMS, we issued an updated Medicaid and CHIP vaccine toolkit that reflects the change in commercialization of the COVID vaccines, as well as the Inflation Reduction Act provisions that impacted mandatory coverage of vaccines for adults in Medicaid. And those are my updates.
Thank you very much, and thank you for sharing the news about Dr. Kelman. That's a real loss, and we certainly, many of us worked with him, and we will certainly all miss him. So thank you for sharing that with us. Dr. Kaslow? Just a moment. Dr. Cotton?
I just wanted to acknowledge Dr. Kelman and his contributions to the work group, to the RSV vaccine work group. He was really amazing. He was so helpful, and he was always willing to talk with me outside of, the work group to explain some complex HHS policies and other things, and he was really just very wonderful to work with. So I'm so sorry to hear the news. Thank you.
Thank you, Dr. Orton. Again, David Kaslow, Director, Office of Vaccines Research and Review, CBER FDA. FDA colleagues also mourn the loss of Dr. Jeff Kelman. So since the last FDA agency report at the October 2023 ACIP meeting, and apropos of today's discussions on chikungunya, FDA approved IXCHIQ, a vaccine indicated for the prevention of disease caused by chikungunya virus in individuals 18 years of age and older who are at increased risk of exposure to CHIKV. And as noted earlier today, this indication was approved under accelerated approval based on anti-CHIKV neutralizing antibody titers. Continued approval for this indication may be contingent upon verification and description of clinical benefit in a confirmatory or in confirmatory studies. And the highlights of the U.S. prescribing information include warnings and precautions that IXCHIQ may cause severe or prolonged chikungunya-like adverse reactions. Other regulatory actions include scores of supplemental biological license applications, some pertain to manufacturing changes, some to labeling changes. Given the hour, I'll spare the committee a rundown of those regulatory actions. But rather, given tomorrow's ACIP agenda, I'd like to highlight the work FDA continues to do to monitor the safety and effectiveness of vaccines for respiratory illnesses using the Biologics Effectiveness and Safety System, dubbed BEST, and the Centers for Medicare and Medicaid Services, or the CMS system. Ongoing projects include safety and effectiveness of RSV vaccines, influenza vaccines, COVID-19, 2023-2024 formula vaccines. And you'll hear the results from some of that work tomorrow. Although the Vaccines and Related Biologic Product Advisory Committee has not met since the October ACIP meeting, looking ahead, FDA anticipates convening of VRBPAC twice before the June 2024 ACIP meeting. Next Tuesday, the 5th of March, VRBPAC is scheduled to meet in open session to discuss and make recommendations on the selection of strains to be included in the influenza vaccine for the 2024-2025 influenza season. And as mentioned earlier today, on the 16th of May, VRBPAC is scheduled to meet in open session to discuss and make recommendations on the selection of strains to be included in the 2024-2025 formula for COVID-19 vaccines. And other convenings of VRBPAC may occur as needed. As in the past, I'd like to take this opportunity to personally thank the review teams, their supervisors, and management at CBER who work to continue diligently to conduct research and review to protect and enhance public health. I'd also like to thank the many staff here at CDC for their many contributions and their collegial celerity to our collective efforts to protect and enhance public health through immunization. That concludes FDA agency report to ACIP.
Thank you, Dr. Kaslow. And I think we've all been so impressed by the power of the CMS data that you all have used for safety surveillance and studies. It's, as we're thinking about vaccination of older adults, it's ultimately the way we're going to get answers to so many questions that are important. So, Dr. Lair.
Dr. Kaslow, just sort of speaking as a member of the public, could you sort of give us a sense of when information becomes public knowledge? So if a pharmaceutical files a BLA, or if they're doing a phase 1 study, when does the public learn about those kinds of information?
I think there's two ways that the public may become aware of it. The first is the sponsor or the applicant. They are free to make available any communications they receive from the FDA. We are not allowed or permitted to make those public information until the time of a regulatory action. And both through emergency use authorization and the BLA approvals posted on our websites in a timely way are all of the documents redacted for proprietary information that went into that regulatory action decision. So you can find the clinical memos, you can find the chemistry manufacturing control memos that went into that regulatory action on our website. It's redacted of proprietary information, but it has all of the information that was used to make that decision. Hopefully that answers your question.
Exactly. Thank you very much.
Well, and just to add to that, of course, if a sponsor does a phase 1 or phase 2 study, separate from it being submitted to FDA for regulatory consideration, they certainly can present it at a meeting, put out a press release, share the information separate from its submission to FDA.
And you should be able to find some of that information on clinicaltrials.gov.
So thank you. Commander Grimes?
Thank you. So the National Vaccine Injury Compensation Program, or the VICP, continues to actively process claims. In fiscal year 2024, as of January 1st, petitioners have filed 314 VICP claims. Over 41 million was awarded to petitioners, and over 13 million was awarded to pay attorneys' fees and costs. In addition, the VICP had approximately 600 claims alleging vaccine injury awaiting activation for review. Previously, there was nearly a 12-month wait period between when a petition was found to have adequate medical records to review by a HRSA provider and when a review was completed. As of January 1st, 2024, the wait period has been reduced to less than 1 month. More data about the VICP can be found on our website. For the Countermeasures Injury Compensation Program, or the CICP, in the decade prior to COVID-19, fewer than 500 claims had been filed with the CICP. CICP received a direct appropriation for the first time in fiscal year 2022, and the program has used those funds to increase its capacity to conduct medical reviews by hiring and training new review staff and contractors, as well as to pay compensable claims and improve IT and other communications with requesters. As of January 1st, 2024, 12,854 claims alleging injuries or death from COVID-19 countermeasures had been filed with the CICP, including 9,682 claims alleging injuries or death from COVID-19 vaccine. CICP has rendered decisions on 2,214 COVID-19 claims as of January 1st, 2024, representing more than 4 times in the prior decade. More information about the CICP can be found at its website. Thank you.
Thank you. Any questions for Commander Reed? Commander Marshall.
Good afternoon. I will provide an update on behalf of the Office of Infectious Disease and HIV/AIDS Policy within the Office of the Assistant Secretary for Health. The Interagency Vaccine Working Group of the U.S. Department of Health and Human Services is scheduled to convene in March 2023 to deliberate on an interagency progress report which addresses the achievements and strides made from 2021 to 2023 towards achieving the goals outlined in the Vaccines National Strategic Plan. This collaborative effort underscores the commitment of multiple federal agencies toward transparent communication in the pursuit of vaccination goals. The National Vaccine Advisory Committee held a meeting on February 22nd and 23rd to discuss critical policy matters related to vaccination. The committee's deliberations included a discussion on the resurgence of measles cases, which underscored the pressing need for proactive public health measures to improve vaccine confidence and counter misinformation about vaccines. This concludes my report. Thank you.
Thank you, Commander Marshall. And Dr. Beigel.
Good afternoon. I have several updates from the National Institute of Health on vaccine-related research that I think will be of interest to the ACIP. First, an update on NIH leadership. In November 2023, Dr. Monica Bertagnolli started as the 17th director of the NIH. She is the first surgeon and second woman to hold the position. Nominated by President Biden, she was confirmed on a bipartisan basis in the U.S. Senate and transitioned from her role as director of the National Cancer Institute, a position she held since October 2022. For COVID-19, there are two studies I would highlight about the value of maternal vaccine. First was a study that demonstrated maternal vaccination may prevent infant COVID-19. In a cohort study, researchers aimed to quantify protection against infection from maternally derived vaccine antibodies in the first 6 months of an infant's life. Higher transplacental binding and neutralizing antibodies substantially reduced the COVID-19 infection in the infants. Until infants are age eligible for vaccination, maternal vaccination provides passive protection against symptomatic infection during early infancy. These same findings extend to preterm infants. In a separate study that was shown that preterm infants born to people who have vaccinated for COVID-19 have roughly the same antibody titers as those of term infants. Moreover, in all infants, antibodies to the spike protein were higher among those born to individuals that received 3 or more vaccines before delivery compared to those that only had 2. These findings may help allay concerns that fewer antibodies might pass from preterm infants compared to term infants. There are 2 studies I would highlight about ancillary benefits of COVID-19 vaccines. First is a prospective cohort study of adults. Researchers identified SARS-CoV-2 infections and followed them for the presence of post-acute sequelae and long COVID. Vaccination not only prevented disease, but was associated with lower prevalence and severity of long COVID symptoms. There was also an interesting study about looking at the spike in preterm birth rates that started at the beginning of the pandemic. That analysis showed that by late 2022, widespread COVID-19 vaccination in pregnant people likely halted the spike in preterm infants, and those rates have come down towards normal. This underscores the need for pregnant people to keep current on COVID-19 vaccination. Lastly, for COVID-19, I would just highlight in October 2023, the Nobel Prize for Physiology and Medicine was awarded to Dr. Drew Weissman and Catalin Carrico for their work on messenger mRNA that enabled the mRNA vaccines. It's important to highlight the science that enabled those vaccines did not happen overnight. Dr. Weissman, Dr. Carrico had decades-long work messenger RNA with incremental steps in the science, but ultimately those steps and those scientific advancements were critical to enable the unprecedented development of the mRNA vaccines that stemmed the pandemic. For influenza, I would just highlight one study. There was a study that evaluated 2 doses of high-dose influenza vaccine compared to standard dose in a pediatric hematopoietic stem cell transplant population. The high-dose vaccine resulted in higher antibody responses, especially for flu A. Because flu causes substantial morbidity, mortality in that population, optimization vaccine strategies is critical, and the use of high-dose inactivated vaccines may be a practical strategy to overcome the poor immunogenicity in that population. Additional details and links for all of those that I mentioned, as well as other updates on vaccines for CMV, dengue, HIV, will be provided in a written summary. And this concludes the updates from the NIH.
Thank you very much for that update. I appreciate all the updates from our HHS colleagues. It really illustrates the wide range of vaccination efforts across Health and Human Services, and we appreciate the updates and continued collaboration across the federal agencies. As far as the agenda is concerned, the committee has completed its business today. Are there any objections to adjourning today's meeting? I am not. We don't need a motion for this. We can do this without a motion. Hearing no objection, today's ACIP meeting is now adjourned. We will reconvene tomorrow morning at 8 a.m. Eastern Standard Time, and thank you in particular to our ex officio members who we called upon to play a different role today. So thank you all very much, and thank you to the rest of the committee.